Okay, welcome everyone back from spring break. We're on to week 6 of epidemiology. So, just to give you a quick recap, so far in this semester, we've done a lot of work setting up the basics of how we measure disease through prevalence and incidence primarily. We've also talked about descriptive epi studies where we start to understand trends in person, place, and time for our health outcomes. And then we went on to talk about causality and the sort of philosophical side of why we're trying to get at causality and some of the methods that people have tried to use to conceptualize causality, whether they're causal pies or webs of causation or Bradford Hill criteria. So we're going to put all of that background knowledge aside for a bit, or not aside, we're going to keep our background knowledge, and we're going to move on to talk about the field of analytic epidemiology. And now I've referred to this a few times, but we're really moving from the idea that we're just describing the health of populations to figuring out how can we test whether something causes something else. And as you guys know from the causality lecture, it's very hard to figure out if something causes something else. So we have a lot of study designs that try and approach this in different ways and see if we can start basically to test hypotheses and rule out whether something does not cause something else. So today we're going to be talking about cohort studies, which are one specific type of study design that get us a little closer to causality, and you'll see what I mean. And our first lecture is going to be talking about what are cohort studies and how would you implement a cohort study. And then our second lecture is going to go into some math based on the incidence information that we can get from cohort studies. So there's going to be 2 lectures today. So analytic epidemiology. As I was saying, it's the study of the determinants of the disease. It allows us, these study designs allow us to test hypotheses about whether something is associated with something else. So again, we're moving on from just describing trends and we're starting to test hypotheses about, ultimately did something cause something else to happen? And we have 2 types of analytic study designs. We have observational studies and experimental studies. In observational studies, the investigators do not intervene on the study participants' exposure status. We basically observe. We watch people in their day-to-day lives, and exposures are naturally assigned. People choose to smoke, people choose to drink, people live in a certain neighborhood, they're exposed to a certain drug, things like that. Those are observational studies. And within observational studies, we're going to talk about cohort studies today and case control studies next week. And then the other type of analytic epidemiology is experimental studies. And in that case, the investigators do assign an exposure to study participants. We say, you are going to take this drug, or you are going to be exposed to this policy or educational lesson. And specifically in this course, we're going to talk about randomized controlled trials. And the key thing with randomized controlled trials is that the exposure is randomly assigned. And that gets us all sorts of amazing benefits that we will talk about in a couple weeks. But today, we're going to talk about cohort studies. So in a cohort study, the bottom line is that individuals are selected based on their exposure status. So we recruit people and we measure their exposure, and either by virtue of the way we recruited them or just because we happen to have a big enough population of people, there's going to be a variety of exposures. So there's going to be some people who smoke and some people who don't smoke, some people who drink and don't drink, etc., etc. So we recruit those people, we measure their exposure status, and then we follow them over time, and the incidence of our outcomes of interest is measured, right? So if you remember back to incidence, what incidence was new cases of disease over a specific time period. A cohort study aligns perfectly with that. So we have our disease-free group of individuals, we assess their exposure, and we watch over time for new cases. Voila, we can end up getting incidence. So the specifically note the red terms here because those are the key points of a cohort study. So in a cohort study, there's, as with all observational studies, there's no process of assignment to exposure group. The investigator is not in charge of this. So someone just sent me a message. Nature, you could be assigned to exposure because of nature, because you live in a certain area or had a tornado happen. The subject could have self-assigned, right? The subject chose to engage in a health behavior or something else. For you live in a certain place and so you're exposed to a policy or a certain neighborhood characteristic, something like that. The bottom line is that the investigator does not assign the exposure. It comes about by virtue of who the person is, what they choose to do, where they live, all that good stuff. So as I was saying, the investigators assemble or identify a cohort. So the cohort is the group of people, and they assess their exposure status. So we have to measure who's exposed, how much are they exposed, who's not exposed. And this exposure, right, we've talked about exposures. It could be a lot of different things. If it's something like smoking, we need to, do we care about have they ever smoked? Are they current smokers? Are they former smokers? If they're current smokers, how many cigarettes do they smoke a day? That type of thing. There are lots of different ways of assessing exposure status. But we do that at the beginning of our study. And then the cohort members, the group members, are followed over time to assess incident disease. And a key thing is that anyone with prevalent disease at the beginning of the study are excluded. So you don't want someone sick at the beginning of your cohort because then they're not at risk. So again, remember our formula for incidence. Our denominator needs to be population at risk. If you have someone who's sick in the beginning of your study or has your outcome at the beginning of your study, they're not at risk anymore. They should not be in your cohort. Okay, so here's a little study, a little figure showing our study design. So we start with a study population where exposure is self-selected. Again, self-selected should be interpreted broadly. It may be the neighborhood in which you live in. It may be the natural disaster you were exposed to, something like that. And then we end up identifying that we have a group in our population who is exposed to whatever we care about and a group that's not exposed. And then we follow them over time. And among each of these exposed and unexposed groups, some people will develop disease and some people won't develop disease. And just to give you a hint of what's coming, so what we can do is among our exposed group, calculate the incidence of disease, and among the unexposed group, calculate the incidence of disease, and then we compare the two. And then we can say the exposure was associated with this much disease because it's the amount of disease in the exposed versus the amount of disease in the unexposed. Okay, I have these two little example videos here, and I actually have a really good third one in an old PowerPoint. Instead of showing them in this video, I'm going to post them separately because I think the sound doesn't work great when I do a video within a video. But please go watch these because they're really nice examples of cohort studies, and they're actually pretty cute little videos. Okay, so when do we do a cohort study? When would you even decide it's the right time to do a cohort study? So we do it when there's already some evidence about the role of a specific risk or protective factor for the outcome. If there's zero evidence, if you have zero reason to believe that these things may be associated, then you'd probably start with a cross-sectional study or, specifically maybe an ecologic study and just collect some basic data. Is this associated with this? Right? With a cross-sectional study, we can't tease apart what came first. There are a lot of limitations, but you need some basic evidence because cohort studies, as you might imagine, are really expensive. They can be really expensive because you're assembling groups of sometimes thousands or tens of thousands of people, and then following them over time, sometimes like 30, 40 years. It's an incredible investment, and you wouldn't want to end up in a situation where you're not even starting from some hint that something is associated with something. I'm sorry, guys. I think you hear my husband sending me messages. Okay. I can't turn off the volume because of the volume of the video. All right. So, so we also do cohort studies when the interval between the exposure and the outcome is relatively short. So say we had a hypothesis that something you're exposed to prenatally affects you getting cancer when you're 60 years old on average. You cannot do a cohort study, or it'd be very difficult to get funding, to recruit a group of pregnant women, some who are exposed to that thing, some who aren't, watch them have their babies and track those kids until they're 60 years old. Just not possible. But what you can do, right, if you think prenatal exposure to something is associated with a certain genetic malformation that would occur, you'd see it through an ultrasound or when the baby's born, you could do a cohort study then. You can also, and we'll get into this a little later, you may choose to modify your outcome to shorten the time frame that you need to follow people. So maybe what you really care about is stroke and whether something is associated with stroke, but you can't follow people for a long enough time to watch them get a stroke. So you're going to kind of back up and find a health outcome that's an intermediary. Okay, so we also do cohort studies when an exposure is rare. So the great thing about a cohort study, right, is that we can track down groups of people who were exposed and unexposed to something and follow those people for a long time. So a great example of this is some sort of, environmental or industrial exposure, right? If we want to know that people who worked in a certain chemical factory, whether they end up with types of cancer, we could go directly to people in that factory, right? And our study base may be people in that factory, and our exposure status is people who worked, directly with the chemical versus, a secretary who, was floors and floors away from the chemical and was never exposed. We can go and seek out those exposures and study what happens to those people over time. And then finally, we might conduct a cohort study when the outcome is relatively common, or we need to do it when the outcome is relatively common among those exposed. So if you have a very rare outcome, you may recruit a cohort of 10,000 or 100,000 people, and no one in your study, because the outcome's so rare, no one in your study ends up with your outcome. You have no data. You can't compare then the incidence of your outcome in your exposed versus the incidence in your outcome in your unexposed, because it's just zero. So you need to ensure that you're studying an outcome that's prevalent enough, that's common enough, that you're going to see some outcomes, especially, ideally some outcomes in the exposed and some outcomes in the unexposed, so you can compare. You don't have zeros when you're doing these calculations. Okay, so we talked already a little bit about exposures. So, just go through some examples of the exposures. We may have exposures that are assigned, quote unquote, by the individual. So drinking or not drinking, the amount or regularity of drinking alcohol, having gastric bypass surgery or not. These are all exposures that are chosen by the individual. We could have an exposure that's assigned by the manufacturer or legislation, something, I don't know why subject is there, I think that should be gone. But something sort of outside the individual. So you are assigned or exposed to having a car with an airbag. You're exposed to living in a walkable neighborhood. Or finally, we may have an exposure that's assigned by nature. So you have a certain genetic genotype, or you've experienced a natural disaster, right? You guys can think of all of these examples. And the key with a cohort study is that it is not the investigator saying, you're going to have a car with an airbag and you're not, and we're going to see what happens. It's people are choosing these things for the most part. And so when we select our cohort, we enroll disease-free participants who are either, clearly exposed or unexposed, or they have gradations of exposure. And then we, just for some language, we have our exposed and then our unexposed, right? And our unexposed, if you ever see this, are sometimes called our referent group, our comparison group, something like that. And a lot of times, you'll have to kind of think hard, well, what's my comparison group? Like if I'm interested in people who are taking a certain medication, you want a reference group. What's your reference group? Is it people who have the same condition who don't take that medication? Is it people who are healthy and don't take that medication? It makes a big difference who you pick. So again, I feel like I'm repeating myself 5 times. Oh, no, because I just read that, that's why. So a cohort study can recruit one population group or cohort and identify varying levels of exposure within that group. So this happens a lot. So I have this example. I worked on a study called Project EAT where we went into middle and high schools and we recruited 4,500 students. And within those high schools, there's a range of exposure status, right? So some of those kids are obese, some are not obese, some of them have healthy diets, some don't have healthy diets, et cetera, et cetera. So we took a population-based sample, and because of what we know about American teenagers, we knew that we would get some variation in exposure. Or the alternative is that 2 cohorts can be selected, an exposed and unexposed. And again, this might be important if you have a rare exposure and you really need to track down people who have and do not have that exposure. So an example of this, there was a big study called the National Children's Study that was at multi-sites across the country. And a couple of years ago when I first taught this class, I had a woman in my class who was working for the National Children's Study. And she was at CHOP, and for her site, what the National Children's Study was doing was looking at people who lived in Schuylkill County versus people who lived in Montgomery County and the babies that were born to these people. And the idea is that the people in Schuylkill County were exposed to much more pollution than the people in Montgomery County. So in that case, they recruited essentially 2 separate cohorts who they knew had varying exposure status. Oops. Okay. I didn't realize I could zoom in on that. All right. So let's start to go back to the idea of the counterfactual, because this is where it becomes really important. So again, the counterfactual is what would have happened to that person but for the exposure, where the only thing different between these, let's say, 2 people or the same person is that exposure, right? The problem in a cohort study or when we're not assigning exposure is that when individuals choose their exposure or assign to them non-randomly, the exposed and unexposed groups differ in a lot of different ways than just that exposure, right? So behaviors cluster together. We've talked about this a lot. People who smoke tend to be more likely to drink alcohol, tend to have other health behaviors. So someone who's assigned to smoking has a lot of other differences than a person who doesn't smoke. And so our exposed and our unexposed are not the counterfactual to each other. So let's just go through a few examples of this. So if we wanted to look at the association between maternal smoking and infant birth weight, we'd end up recruiting cohorts of women and ending up with some variation in how much these women are smoking. But the problem is that women who smoke during pregnancy are very different than women who don't smoke during pregnancy on average, right? They may be lower socioeconomic status, they may live in different neighborhoods, they may be doing other, health behaviors or not doing health behaviors during their pregnancy. And then it becomes the issue of how do you, if these women who smoke are so different from these women who don't smoke, when you're looking at infant birth weight, how do you tease apart what was the smoking and what was all this other stuff that went with it? We can go through these other examples if we want to look at the association between neighborhood air pollution and child asthma. What's different about people who live in a highly polluted neighborhood versus people who don't? And so maybe it's socioeconomic status, right? We know there's this history in the US that highways and airports and all these really pollution-causing things are put in poor neighborhoods because those poor neighborhoods have very little political capital to say, no, you're not coming into my neighborhood. So there's different things about kids who live in neighborhoods with high pollution that may be also associated with asthma. And again, we can't tease the exposures apart. Another one, worksite chemical exposure and lung cancer. What else is it about people who are exposed to these chemicals that might make them more at risk for lung cancer? In which case it's difficult to tease apart what was the chemical exposure and what wasn't. Okay, so there are characteristics that differ across our exposed and our unexposed groups. that confound the association. Remember, we've been sort of introduced to the idea of confounding up until now. This is where we have confounding. These differences between your exposed and unexposed confound the association between your exposures and your outcomes. So confounding is a mixing of effects. When exposures cluster together, it's difficult to disentangle, if any, which of the exposures caused your disease. So, let's go back to maternal smoking and infant birth weight. You might say that maybe women who smoke during pregnancy don't take prenatal vitamins. And so you don't know whether it's the smoking or the lack of prenatal vitamins that are influencing the birth weight. And you would say, or you would wonder, is prenatal vitamin use confounding the association between maternal smoking and infant birth weight? Is it causing this masking of effects, a masking of an association? You may see an association between smoking and birth weight, but it's all due to not taking prenatal vitamins. The prenatal vitamins were confounding the relationship. Okay. So let's think about timing of cohort studies. So there's basically 3 different types of cohort studies that all relate to the timing of when the investigator sort of starts the study. The most common cohort studies you'll see are prospective cohort studies, and this is what we've talked about, that disease-free participants are grouped based on past exposure or current exposure, and they're followed into the future. It's what you would, again, typically see in what we've talked about. We can also think about retrospective cohort studies, and the idea there is that say you were in a situation where wonderful records were being kept, right? In a lot of the Scandinavian countries, we have incredible birth and death registries where we basically know what people have been exposed to and what health outcomes they've had for most of their life. So an investigator could start a study and go back to a group of people born in 1920 and look at what they were exposed to and unexposed to, and then sort of look through the medical records and see what disease outcomes occur. Actually, there's the most common retrospective cohort studies that I come across are things that captured, generations that were maybe exposed to famine, right? And then they know what health outcomes occurred among kids who were born in years of famine and kids who were born not in years of famine. So that would be a retrospective cohort study. We can also have these weird ambidirectional mixed cohort studies where you kind of start in the middle and you're using some exposure and outcome information that's already happened, and then you also track people into the future. What was I going to say about this? The key with cohort studies, though, and how they differ from what we're going to do next week, which is case control, is that you're assessing people's exposure status and you're looking over time to see when outcomes develop. In all of these types of studies, you are selecting people on exposure and watching for outcomes, even if the watching is just looking through the medical records. This is key. Okay, so why would we do a retrospective cohort study? If we have existing records and we can reconstruct the cohort and their exposure and outcome status, and really, usually it's faster and less expensive, right? If you just want to go to a hospital and sit in the basement and dig through records, which I have done in my past life as a research assistant. All right, so here's just a little visual where the investigator is sort of at the end of the study and they're going back in time. But again, the key is that they're assessing people based on exposure status and watching over time for case development. Alternatively, a prospective cohort, why would you do it? You have more control over your cohort selection. You can measure exposures the way you want. Say you care about an exposure that can only be self-reported, that was never captured by records. You need to do a prospective cohort study. You can have much more control over follow-up and how you measure your outcome. If your outcome is diabetes, do you care about diagnosed diabetes or fasting glucose levels? You can make those decisions. And you also have a greater ability to account for all those other variables that go along with your exposures and mix up your estimate of effect. So say you know that smoking is important, or the person's gender is important, or race is important, or if their parent died is important. You can collect all those things when it's your new group of people that you're watching over time. So here's our example. We have our investigator who's starting with a study sample. They screen people to make sure they take out people who are already sick, so not at risk anymore. Then they measure their exposure status and follow over time. Okay, so when we're doing our cohort studies, as I've been saying, it's important to assemble a cohort that's at risk for the disease, right? Think again about your formula of incidence. You would never want someone in a cohort study who could never develop the disease. They couldn't go into your incidence measure. It would be silly to watch them. So we need them to be at risk for disease. And then we also want them to have not a history of the disease or undetected disease. And the idea here is that cohort studies, because you're assessing exposure in disease-free people and then looking at outcomes, you hope to be pretty darn certain that your exposure happened before your outcome. The problem is when people either have a history of a disease or they have undetected disease, essentially their behavior, their exposure status may already start to be affected by either that history or that subclinical disease, right? So say you're interested in stomach cancer and you had someone in your study who has undetected stomach cancer, but they know they've been having a lot of stomach discomfort. They may already be changing their diet. So if you're interested in, does diet lead to stomach cancer? When you measure the diet of that person who has that undetected disease, you're going to get sort of a false reading on what their diet is because the disease came before the diet. You need to be able to take out your people with a history of disease or undetected disease because they've already changed their exposure status in response to that disease, or at least there's a risk of that. Then once we have our disease-free cohort, we like to assess our exposures. We need to assess our exposure. It's really important to be as specific as you can about the exposure of interest. You don't know how many times people kick themselves and sort of wish they had assessed the exposure differently, right? So if you're interested in smoking, you're going to want to ask a lot of really good questions about smoking. Again, former smoking, current smoking, how much? Are you smoking menthol cigarettes? Are you smoking e-cigarettes? What brand, so you can know the nicotine content, all these different types of things, because you can then maybe potentially start to separate out, okay, actually people who smoke e-cigarettes have a different disease trajectory than people who smoke regular cigarettes. And then we also want to think about the latent period of disease. So what's the period between when they're exposed to a disease and we would want the disease to develop? And this goes back to the idea that, traditionally you can only follow cohorts. NIH will only fund a cohort for 4 or 5 years. So you better be darn sure that some disease is going to develop or some, precursor to disease will develop in that period. So you need to be aware of, for your disease, what is the latent period? What is the period between when we expect the exposure happens and the disease happens? And is that latent period short enough that you can capture disease? We also often want to collect exposure data dynamically as your cohort study goes on. So with diet, right? So say you started your cohort and you measured their average overall diet over the past year, and then you're going to follow them for 20 years. Well, chances are, or what you should do is maybe every 2 years re-measure their diet, right? Because diets change. There are fads. There's, new knowledge of what we should be eating. People are now eating kale and quinoa, and they didn't do that 20 years ago. And so you want to know, the exposure to diet is not static. It changes, and you want to be able to incorporate that change into your outcome. So is it not just what people ate 20 years ago that's associated with your health outcome, but if you change your diet over time, is it the people who increase their red meat consumption that get the sickest versus people who just had the high red meat consumption, something like that? That's why you'd want to, often in our studies, we reassess exposure. We ideally want to have objective measures of exposure. So anytime you can have a biological test or, a verified, yes, this happened to this person or this neighborhood characteristic was there, that's better because people do a pretty terrible job about reporting what they've been exposed to. Although we do use self-report data. I mean, that's all you can get, right? Like if you want to know if someone's exposed to depression, well, I guess you could have a psychiatrist interview them. But most often we're going to ask someone, did you feel sad? Did you cry? Those type of things. And something important to consider is that there may be different accuracy of reporting based on their person's exposure status or a lot of different things, right? So like someone who does eat a lot of red meat, they may be hesitant to tell you that because they think it's a bad thing. So there's always concerns about measurement and whether there's bias, so whether people differently report their exposure status. Okay, and so similar to when we're measuring exposures and assessing exposure status, we want to be really precise and careful on how we follow up our cohort and how we measure outcomes. So, right, we've assessed exposure status in our cohort and then we follow them over time. What we want is complete follow-up of all of our cohort measures. You never want to lose someone and not know what happened to them. It happens, but we don't like it. We want complete measurement of outcomes. We want, again, to know for every person in your cohort, at every measurement time, did they get this outcome or not? And we want that to be standardized. So we use a lot of methods of tracking people in our cohort. It's important to collect extensive contact information at recruitment. Studies I've worked on say, what's your phone number? What's your mom's phone number? What's a friend who will always know where you are? And it's really hard now that people don't have, I guess now people are using the same cell phone numbers even when they move, but during a period probably 5-10 years ago, people changed their cell phone number every time they moved and it was crazy. So people use government records, they can do credit card searches on people, internet searches. There's the National Death Index where you can search death certificates. There's all sorts of ways that we follow people because we want to know, again, for every cohort member, what happened to them. Did they end up getting our outcome or not? And ideally, say cancer is your outcome, you're going to want to know, be able to look in the SEER cancer registry, did this person actually die of cancer, even though I couldn't find them for my study, because you want to know your outcomes. And when you measure your outcomes, as you can imagine, there are lots of different things we can be looking for, right? We could be looking for death. Is something associated with an increased mortality rate? Do we want to look at incidence disease? Do we want to look at reoccurrence of disease in a cohort? Does dietary quality prevent the reoccurrence of certain cancers? Or just in general, a change in a measure of health risk. So, obesity studies. So is early childhood parenting associated with incident obesity as children enter grade school? That might be a question that you answer in a cohort study. So similar to our exposure ascertainment, we can use direct methods to assess outcomes. We can ask people questions, do interviews. Ideally, we have biological specimens and lab tests. And you really want to make sure that even when you have a biological specimen, there's often a subjective experience there. So, right, maybe you have an MRI or an X-ray of someone, and you need to make sure that the physicians in your study are reading that MRI or that X-ray correctly, and that actually they're not affected by, say, knowing someone's a smoker or not a smoker when they look at an MRI, because that's going to mess up your association between smoking and this outcome. Similar to tracking people, we can also use indirect methods to assess outcomes. We could look at surveillance systems, registries, records, right? There's a lot of ways that we don't necessarily need the patient there telling us what happened to them so we can ascertain their outcome. Okay, so the strengths and limitations of cohort studies. So the strengths of our cohort studies, as I said, the temporality of exposure and outcome is clear. You have set it up that you know the exposure happened before the disease, right? Remember back to our Bradford Hill criteria, that is critical. Remember even our causality, fundamental to the definition of causality is that the exposure has to happen before the outcome. So cohort studies are very good for common outcomes that occur in a relatively short time frame. Again, we want to have enough people getting your outcome of interest. We don't end up with zeros everywhere. And it needs to happen quickly enough that we can get funding to study it. Useful for rare exposures, we can really select on who we look at as our exposed group. And they can be used to study multiple outcomes, right? It's all about what you measure. So say you have your cohort study that's looking at people exposed to air pollution in one neighborhood versus not, less air pollution in another neighborhood. If you are smart and thinking ahead, your primary outcome may be asthma, but maybe you have a whole bunch of secondary outcomes. Maybe you're looking at ear infections or child development or educational outcomes, that type of thing. You can, the limit, if there's a limit, the limit is only, your creativity and your money. You may be able to study multiple exposures also, as I mentioned in our Project EAT study when we went into high schools. Because of what we know about US kids, we knew, okay, we're going to get a variety of exposure on obesity and on dietary intake and on physical activity and on drug use. So you can do many, many studies. And often these big cohort studies, they're sort of big standard cohort studies in the US that have been following people for a long time. And you get a lot of different papers out of that. Like one of those videos is about the nurses' health study and the physicians' health study. I can't think of the right name of it. But basically those are two big cohort studies out of Harvard where they took a group of nurses and they took a group of physicians and they followed them over time. And we've gotten a ton of information about what to eat and what not to eat from those studies. And if any of you are paying attention to the new nutrition standards that were just, the dietary guidelines that were just released, there's kind of a big complaint that all of our dietary data, or most of our dietary data, are from these cohort studies of nurses and doctors at Harvard. And the question is, are nurses and doctors different in ways that make those findings not generalizable to the public? And do we do a good enough job at measuring what people eat that we can even say that we know what causes health? That's a whole different conversation we can have. And so another final strength of cohort studies is that variations in exposure over time can be taken into account, right? If we're tracking people for 20 years, we can look at who's stopped and started smoking, who's stopped and started medication use, who's changed their diet, who's changed their, preventive care practices, who's using IV drugs and who's not, all those types of things that you can look at and see how those patterns of use end up related to your outcomes over time. Limitations. We often need really big samples. Most health outcomes are not super common, luckily. So you may really need a cohort of 10,000 people to end up with enough breast cancer cases or colon cancer cases that you can say something about what led to those cases. We have a big potential for loss to follow-up over time, right? People move, they don't want to deal with you anymore, they're tired of doing surveys, you lost their address. We lose people, and right when we lose people, our calculations of incidence, who's in our population at risk, are sometimes biased, right? Or sometimes wrong. In a best case scenario, you're tracking person time and you know when you've lost someone, but say you only do follow-up studies every 5 years and all of a sudden you just can't find someone. What do you say about the person time that person contributed to your study? It's really difficult. So this loss to follow-up, it induces bias, which means that it induces systematic or regular errors into your data, right? Because certain people are more likely to be lost from studies than other people, and those people in general tend to be less healthy. They tend to get disease more. The people who are lost are often different than the people who aren't lost, and that causes errors. It also affects your statistical power. So when you start a cohort study, you sort of calculate and say, yes, I know I need 10,000 women to see this many outcomes of breast cancer, and I think that with exposure to this chemical, that the incidence of breast cancer in this group will be this, and this group will be this, and I'll be able to tell those two groups apart. Well, as you lose people from those studies, it becomes harder and harder to tell people apart, just because of statistical power and the way our central limit theorem works. There's also huge potential. I mean, it's intrinsic in our studies that confounding will occur when exposure is not randomly assigned. Again, for 99% of the exposures we look at, they cluster with other things. And so it can be hard to tease apart, is it the drinking or is it the smoking? Is it the maternal smoking or is it the vitamin use, right? We have ways to do it, but it is always a remaining question of whether this is actually a causal relationship that I'm looking at or something else is explaining this. They're really inefficient for rare delayed outcomes. We talked about that. You're going to end up with zeros. You're going to end up with no one getting sick, and your whole study is a bust. They can be a really high burden on participants. A couple of years ago, I had a friend come do a guest lecture about one of the studies she works on where each participant, I think every 2 to 3 years, comes into the university and takes like an 8-hour battery of tests because they're looking for subclinical cardiovascular disease. So they have to take these ultrasounds of the heart and look at how good your blood vessels are and then take all this blood and do blood pressure, and it's really hard on people. And then you also need to ensure that there's sufficient variation in your exposure status. Ideally, you've done enough research ahead of time to know that, yes, I'm able to separate. I have enough people who smoke in my cohort. I have enough people who take this drug in my cohort, that you're going to be able to tell differences between your exposed and your unexposed. Okay. So this is the end of video 1, and we will, in just a minute, move on to video 2, where we're going to talk about the math behind taking the data from cohort studies and what do we do with it math-wise to be able to say something about exposure and disease.